We're going to begin today with an opening ceremony conducted by Lena Ivik, President and founder of Fnigc Center, located in Iqaluit, Nunavut.
Unusakut, huyan namik, tamani takustawi narata ulumi, amma pigearutigi naratigotanna, ikum sarlogo kullir, Inuit kullinga. Good afternoon, and I'm very pleased to be here to start your important session through lighting up takullak, which is our Inuit oil lamp. Taima taana kullak ikipattavullumi katimanauleraimat pillariusugiyattinni pimmariugiyattinnillu pillerinialeraigatta kisianili makimat yutigilautagu teissumani nunamiutautilluta immininatsia asittinni silaqqatittinni silaqluamiungoqatittinni tukumaaqangittiartilluta taanna pimmarigilautavun sunalimaamu tukumaaqangigutigigiallalauqqavut sunalimaatsia tappaniittut nunattinniingaangammata imattinni sikuttinnit uumayuttinni nunamillu tamaanga taakkua manivut nunattinniaqqaagu tamaa piruqpakkami aqqaagulimaamut naammanaartugi nuappalauqqavun allaangulauqtaratamanna upinnarani nunaqalaugatta taqqaani makimalluta ilaannikkun annaumat yutigileqattartugu ajornarneq ilaannikku tikisuungumma taimangalimaa kisianili qaumanermut uqquunermut neqiliorutiqariaqarnitinnu imiriaqarnitinnu uunartunik ammalu sikumiutaummata tamakkua angunasuktivut silamiutaugatta taissumani paneqsait yutituulaormiyo qanulimaatsia una uumatittilauqtu uvattinnik angutaanna uqsuqartittijivut taqqaungarpalauqtu qautamaat angunasugiartu ileqqusiulaorma tamanna taissumani taimaasuorlu qautamaat iqqanaajariaqattaqatta ilavu pitsutigillugi inuugiaqarnivu pitsutigillugu taimailaormata sivuuraneq pigijaulaungitta qaujimagami piyunnanerminni tatigiyanga piyunnarminni taanamatuersitsutigipappavut sivulivut iqqaumallugi quyannameertugi amma matusiniarmigamagu ikummasarlungasuli tappunga noqqatuinnakainnalertunga akuniuniangimmat taanna pijariruteqarumayunga kissiani pijariruteqaruminaqattanga ingertuni pissermik soorlu ilisimayattinni innatinni sivulittinni. I will speak in English during the closing ceremony and share a few things that I just said in my language. But to close this opening ceremony, so you may start your agenda, I will finish with an Ayaya song that we learned from our elders. Nakomek, thank you. I'll see you in a bit.
Lena, thank you very much on behalf of the panel and the center. I think I speak for all of us that you've started us off in the right way. I just want to get to some housekeeping notes. The first note being, obviously there have been, or it will be soon obvious that there have been some last minute changes to the program. I'd like to direct your attention to the screen. Please take a look at the new amended lineup to see these changes. We now have 4 presentations rather than 5, and we will have some new speakers. We will go through that as the event progresses. I just want to let folks know that, of course, we're going to be having 2 Q&A sessions. They're staggered. And any questions you may have, we would ask that you submit them using the Q&A window. These can be questions for the panelists. They can also be technical questions if you're having issues with Zoom, audio or video. Also want to let you know that links to any resources mentioned will be posted in the chat window. I also want to say a quick hello to those of you who may be watching on YouTube. I know this is a very popular session, had a lot of enrollment. The comments function has obviously been disabled, so you will not be able to submit any questions that way. Today's session is being recorded and will be available on the NCCIH website. And just to let you know, there may be some brief pauses as we switch back and forth between presenters. We're pulling together a lot of people from a lot of different places through the miracle of the interwebs. So just a quick session description. As noted, the focus of this webinar is to understand data collection on COVID-19 cases for First Nations, Inuit, and Métis populations in communities. As noted, there are now 4 presentations for this session. There will be full bios of the presenters and the online program posted in the chat. And so, without any further ado, let's get underway. We're going to start with our first panel here today, entitled Building the Framework for a National First Nations COVID-19 Dataset, presented by Dr. Jonathan Dewar, Executive Director of the First Nations Information Governance Center. Jonathan is of mixed heritage, descended from Huron-Wendat, French and Scottish-Canadian grandparents. He will be joined by the First Nations Data Center Manager, Maria Santos. Welcome, Jonathan and Maria.
So thanks, Rick, and thanks very much, Lena, for the opening. It's good to know that we've started this virtual session in a good way. I'm going to do a very quick overview of the First Nations Information Governance Center, and then pass it over to my colleague, Maria, who's going to talk about the national level COVID-19 work we're doing to support First Nations across the country. So as you can see from this first slide, my name is Jonathan Dewar, and I'm the CEO at FNIGC. I've been with the organization now for over 3 years. Maria's been with the organization for a bit longer, so has really been able to see the work develop over a number of years, from our focus on national surveys to related work. And obviously, this work we're talking about today touches on all of the different elements of the organization we know as FNIGC. So with that, I'll ask you to go to the next slide. And I will look to move very quickly through these slides. So this first slide is simply reminding you of the length and breadth of FNIGC's experience in this space. The work that we currently do started well over 20 years ago with the creation of what we now refer to as the Regional Health Survey. Also with the establishment of what we all know of as the Ocap principles. FNIGC was stood up as a standalone organization just over 10 years ago, coming up on our 11th anniversary now, and we have continued that work. And so I'll go to the next slide. The most important thing to know about FNIGC is we only exist because the 10 defined First Nations regions choose to come together to do work that is best done or necessarily done at a national level. So a relationship is central to everything we do. We simply can't exist without that willingness by regional partners to come together and to collaboratively, through the governance of our organization, do the work that we have been directed to do by national leadership, regional leadership, and of course our national board of directors appointed from regions. In the last 3 years, I've worked closely with the board to refine what is a new vision for the organization. And you can see it's very much focused on First Nations data sovereignty, with this important distinction that we aspire to see First Nations achieve data sovereignty in alignment with their distinct worldviews. So this is not a one-size-fits-all, top-down national organization in Ottawa approach. This is very much about First Nations, the rights-holding First Nations, determining what direction follows vision. And you can see some of the direction is articulated in our new mission statement. And with that, I'll ask you to go to the next slide. Mission follows vision, and then following mission, of course, are the core strategic objectives that have been set for us as an organization. And I'll just linger quickly on that first bullet. You can see that our approach is community-driven and nation-based. So it goes very much with the vision statement we just looked at. And then I'll jump to that last bullet because it picks up on what I just said about the centrality of relationship in the work that we do. And so our partnerships, our relationships connect regions to strengthen data sovereignty. Next slide, please. If I was to give you the elevator pitch on what the national organization that is known as FNIGC does, it might be this. We, of course, continue to do that national survey work, most well known as the RHS. And then we have our national social surveys. We had one conclude in 2016. We were in the field at the start of the COVID restrictions, and so had to mobilize with our partners to do things quite differently. We've learned a lot from that. It is likely to come up in conversation as we talk about our work. And then there will be a subsequent national social survey that follows the RHS cycle in the coming years, and the focus for that will be children and youth. We also do research that aligns with the priorities that have come out of our 20+ years of national survey work, but also research on data sovereignty, information governance, information management, etc. Following research, of course, is our need to disseminate, and we have a focus on knowledge translation, but we also have a significant focus, though under-resourced, focus on education, training, and capacity development in the area of data sovereignty, information governance, and information management, of course, the Ocap principles, and then the First Nations data governance strategy. And I'm not going to say much more about the strategy there because it's going to come up in some of the words that Maria shares. But if people have questions about that, still very new and very significant piece of work that we have done in the last 3 years, I'm happy to bring that up in our discussion. So if you go to the next slide, I'll just quickly remind everyone what the Ocap principles are. Remind people that FNIGC, we work at the level of educating people on principles. It is rights-holding First Nations that define and implement ownership, control, access, and possession. So if anyone was to be the quote-unquote Ocap police, it's rights-holding First Nations. What we need to ensure is that rights-holding First Nations are able to make informed decisions, and that's why we need to grow capacity in the area of Ocap and all of those other fronts that I just talked about. And next slide. So with that, I'm going to turn it to my colleague Maria, who has been one of our leads on the much more recent focus of our work, which has been working to support First Nations in a response to COVID-19. So I'll turn it over to Maria, and with that, I will mute my mic.
Thank you, Jonathan, and thank you, Lena and Rick. When the pandemic first started, we were asked by one of our regions to prepare statistics to assist with their own emergency efforts. We quickly realized how we could contribute to a region's emergency response. And as a result, FNIGC quickly published a report titled RHS Statistics for Shaping a Response to COVID-19 in First Nations Communities. This paper was intended to support emergency preparedness efforts by providing basic statistics on factors that increase the risk for infection and poorer outcomes for First Nations. FNIGC has also been collaborating on a paper that examines the challenges and limitations of First Nations COVID data. Through engagement sessions with our regions, FNIGC plans to provide a landscape for First Nations COVID data and data governance in the regions, whether such data includes testing information, cases, or vaccination data. This paper will also demonstrate how the First Nations data governance strategy, which was released soon after the pandemic started, how that can be a potential solution to address some of the significant health data governance issues impacting First Nations with respect to COVID-19 surveillance. Lastly, FNIGC has also been working to explore governance and stewardship of the national COVID-19 case dataset currently residing within Indigenous Services Canada. Knowing this data only represents cases among First Nations living on reserve, to include COVID cases among First Nations living off reserve, FNIGC also needs to access First Nations data held at the Public Health Agency of Canada and/or provinces, taking regional processes into consideration. You can turn to the next slide, please. The main problem with current First Nations health information infrastructure is that data sources do not routinely, consistently, inclusively, or accurately gather identity information. Efforts that try to count the First Nations population and capture identity information can be unreliable. And without the ability to identify and count First Nations become invisible within health statistics. And without a true count of the caseload of COVID-19 or the number of tests or vaccinations given to First Nations, the distribution of the disease within the population is not well understood, nor can we assess how well the healthcare system has administered to the population. For the most part, First Nation populations have relied on two sources, either the census or the Indian registry. In addition to taking place every 5 years, the census does not include First Nations who decide not to self-report. It does not include First Nations and communities who decide not to participate because of personal and/or political reasons. And highly mobile, the homeless, as well as individuals with lower literacy skills are also likely not to be counted. As for the Indian registry, it only includes status First Nations. It doesn't include First Nations who lost their status, non-status First Nations, or recent births. Without the ability to create reliable population counts, you end up with unreliable denominators for calculating proportions or rates. To identify events or occurrences among First Nations, the health administration system either relies on self-reports or linkages to the Indian registry. For provinces and territories that rely on self-reports, due to the distrust and experiences with racism, First Nations may choose not to disclose their identity to the healthcare provider and is thus not captured in the COVID dataset. Furthermore, due to the current stress and capacity constraints of the current pandemic on the healthcare system, pursuing the collection of such missing information is not a priority. Next slide, please. For the most part, the Indigenous Service Canada COVID dataset includes First Nations living in communities for which it administers health services. Thus, there's a systematic exclusion of subpopulations of First Nations people according to their place of residence. And for some provincial health administration systems, identification of First Nations occurs through the data linkage to the Indian registry. However, this excludes First Nations who are not registered, First Nations that registered after data linkage occurred, or First Nations registered in other provinces and territories, in addition to the recent births. So provinces that are able to link to their provincial vital statistics are able to address the issue of births. And in an article written by Dr. Smiley and Dr. Firestone, they skillfully demonstrate the impact of misclassification bias, whereby Indigenous events are misclassified as non-Indigenous, more so than the non-Indigenous events being misclassified as Indigenous. And in the article, they demonstrate such misclassification results, for the most part, underestimate Indigenous health and social inequities. Lastly, without the ability to identify First Nations, it makes it additionally difficult to examine, monitor, and address disproportionate effects within certain subpopulations of First Nations, such as gender or people living with disabilities. Next slide, please. Historic and current jurisdictional complexities have been at the root of many of the existing Indigenous data system deficiencies. For example, provincial, territorial health, and public health departments to various extents have argued that historically and currently, Indigenous health, including Indigenous health surveillance, is a federal responsibility. The subsequent result is the underdevelopment of Indigenous health information systems at the provincial level. When provinces or territories have included Indigenous identifiers in their health information systems, they are not collected similarly across jurisdictions. Most recently, CIH has tried to address such differences in their proposal for a pan-Canadian interim standard for collecting race-based and Indigenous identity data. In addition to the variability in the collection and reporting of data from provinces, territories, and federal jurisdictions, the data flow and limitations of the data in the different jurisdictions are not transparent or well documented. As a result of all these jurisdictional complexities, First Nations are included within two different but potentially overlapping data sets that contain gaps. Next slide, please. This non-integration of health information systems between federal and provincial health services and the mobility of First Nations between different jurisdictions has resulted in challenges with notification and tracking for COVID and inaccurate case counts. And since the two federal data sets cannot be linked, duplicates cannot be identified between the two data sets, further creating a fragmented and incomplete picture of COVID among First Nations. Next slide, please. First Nations face barriers for accessing data because the data is often under the control of provincial or federal governments and subject to privacy legislation. Data sharing agreements and partnerships with First Nations and provinces' territories are key to facilitating transparency and enabling First Nations to be able to access their own data. But they require significant effort and collaboration, as well as capacity. For those First Nations that are able to enter into a data sharing agreement, there are often challenges and delays that result from trying to meet what is required by federal and provincial governments for First Nations to receive data, including privacy impact and/or IT security assessments, as well as communication between legal experts, in addition to laying out the foundation for governance protocols. These processes can be held up for many years. These challenges highlight the need to build federal, provincial, territorial First Nations governance structures that support the flow of data and information and the ability to work across jurisdictions, especially during a pandemic. In the process of applying access to the COVID-19 dataset with ISK, we have had to apply under Section 82J of the Privacy Act for research and statistical purposes due to the legislative constraints. However, this is not ideal for monitoring population health. Application for access must be tied to a specific objective. The use of each variable must be justified, and then the data set must be destroyed at the end of the agreement. Understandably, this is a data access management protocol that Fnigc also applies to research projects wanting to access survey data at the data center. However, this arrangement is unsustainable and unrealistic for a First Nations government that is trying to monitor its population's health and administer programs. As we work towards devolution, the data needs to be in the hands of First Nations governments so that they can immediately act upon it. First Nations need to own, control, determine access, and steward their data. Next slide, please. For those regions which have built the relationships, governance structures, and capacity to steward their information, they have been able to disseminate daily or weekly situation reports for both COVID testing and cases on and or off reserve. But this capacity is currently unequal across regions, leaving some regions without information and thus unable to respond. Lastly, the lack of information for small communities due to the measures for protecting individual privacy needs to be addressed. Individual privacy is of utmost importance and needs to be respected. However, how does a community respond in the absence of information? We need to involve our First Nations in how data is put together so that it can still remain meaningful to them. Next slide, please. Last year, FNIGC released the first national strategy to further its vision that every First Nation will achieve data sovereignty in alignment with its distinct worldview. This report represents a collective vision for the future, expressed by First Nations leadership, rights holders, and data sovereignty experts through a series of engagements that occurred over the course of several years. The strategy envisions a First Nations-led national network of regional information governance centers across the country, equipped with the knowledge, skills, and infrastructure needed to serve the information needs of First Nations people and communities, while meeting common needs like data standards and interoperability, so as to be coordinated and integrated at a national level. Anchored in every region, First Nations regional information governance centers can act as a catalyst with the goal to progressively alleviate some of the barriers flowing from an overly complex jurisdictional divide with legislative and policy vacuums. Then they can also enable health data governance partnerships with each provincial government and Canada at the national level. They can also foster coordination for mutually beneficial collaborative initiatives. These apolitical First Nations-led institutions can play a central role as data integrator, with the goal to increase health data access by First Nations governance, health authorities, and professionals. And as a gatherer, packager, and disseminator, the First Nations Regional Information Governance Centers can increase Canada's agility and capacities to respond to health crises events as active participants and key contributors to the Canadian surveillance system. Next slide, please. To address the data quality issues related to First Nation population counts, the First Nations Regional Information Governance Centers would have a mandate to address the issue pertaining to the definition and count of status First Nations as determined by First Nations, the need for communities and their governments to access the detailed information that they need in full respect of privacy and security of First Nations citizens, and to address the data gaps resulting from distrust, racism, lack of understanding, and or lack of processes or willingness for collecting distinction-based data. Next slide. Actually, I'll just skip to the next slide after that. So throughout the pandemic, the completeness, availability, and timeliness of national and regional COVID-19 data on First Nations, regardless of where they live, is an ongoing concern. These issues have collectively impacted the ability of First Nations to respond to the pandemic and plan for the safety of their nations and communities in a timely manner, and has highlighted the importance for First Nations health data governance, digital infrastructure, and information. Although some of FNIGC's regional partners have been successful in entering into data sharing agreements with their provincial and federal counterparts, there is still a tremendous amount of work needed to support these regions in their efforts to address gaps in developing their functions, not to mention the relationships, infrastructure, and capacity that is needed by the remaining regional member organizations that have yet to access their data. The First Nations Data Governance Strategy is an enabler for First Nations to access their information. As data stewards, First Nations will have the opportunity to ask their questions and ultimately make informed evidence-based decisions to respond to the pandemic and combat outbreaks in their communities. As a national data set, the information can be aggregated to look at rare outcomes, at intersectionalities, to examine social inequities. It can provide an opportunity to look at factors that may have been masked within the overall general population. And depending on the information collected, it allows First Nations to prioritize the research questions, evaluate their needs, and bridge those gaps. The proposed First Nations data governance strategy is a unique crossroad opportunity to create the necessary conditions for sustainable dialogues, engagements, collaborations, coordination, and actions for a better health system. Thank you.
Thank you to Jonathan and Maria for your presentation. And we are going to have questions and answers for Jonathan and Maria, but not until after this next panel. And here I am. Boo. And I'd like to introduce our panelists for panel 2, Addressing Gaps in COVID-19, Tracking and Response among First Nations, Inuit and Métis Peoples. Cheryllee Bourgeois is a midwife with 7th Generation Midwives Toronto, and Tasha Shields is a research manager with the Well Living House. Welcome to you both.
Thanks for having us. Great. All right, so I'll get started just by letting you know a little bit about the project that we're working on in Toronto. So the research project that we have is actually partnered with a big part of the research project. It actually is also service delivery, which makes us a unique project. So the We Count COVID-19 is an integrated and Indigenous-led public health approach to First Nations, Inuit and Métis COVID-19 in Toronto. I'm myself and the organization that I work for, 7th Generation Midwives Toronto, is one of the community partners on the project. Can I go to the next slide? Thank you. So we just wanted to share a little bit about an on-the-ground example of trying to collect and really making best efforts to be able to find all of the kind of missing data that the first presentation did so well to explain why that happens, and just to provide an overview of the way that we have the tools that we've created to try and gather and process this data to create, also informed by our integrated public health response. Can I have the next slide, please? Great. So the main thing about the We Count COVID is that it really is, it is built as an integrated public health approach and an indigenous integrated public health approach. So what we do is we work really hard. We provide testing. The other thing that we do is once a positive comes back, we do a case identification interview, and as well as provide some clinical management and support, and then also do Indigenous contact tracing. And then what we do alongside that is we have outreach workers who are involved that then use a model to be able to provide both health and connect people to health and social service supports, to be able to support folks, whether it be through if they're self-isolating, if they're monitoring their illness, and then we're tracking and mapping and trying to understand how to support folks to participate in stopping and reducing the spread of COVID-19 amongst the Indigenous population and the wider population in Toronto. So it really is the clinical and the support or contact tracing is very well integrated. It works out of one place as well as the research. So all of these things are working together, which is can be a little bit complex, but we've found a way to be able to integrate all three and into one spot. Can I have the next slide, please? So just to tell you a little bit about how the project came about, like so many things with COVID-19, it was really an effort to try and get this off the ground and running in a good way that respected the Indigenous community in Toronto and the processes that we use. So it was a partnership between NAMERES, which is Native Men's Residence, SGMT, which is a midwifery practice, and Well Living House. It was funded through a special call through the Indigenous Health Services, which was distinct from the Urban Indigenous Community Support Funds. And it was really designed to address and to respond to the gaps in identifying Indigenous cases, as well as to address some of the gaps that we know exist in the provincial, territorial, and federal responses to COVID in the urban and related homelands. So, for example, something that we were seeing quite a bit in the cities was that there is still many people traveling back and forth from the city back to their home community, and we wanted to be able to participate and provide resources for folks to be able to, if they were continue to do that in a safer way. So it's an action research demonstration project, which means that it focuses on public health service provision, as well as a streamlined project evaluation. So asking people how the services are, while at the same time collecting data around case count, and also finding folks in the city who, Indigenous people in the city who have had COVID, who haven't been identified in the other ways. So the first presentation was actually a great presentation to demonstrate all the ways where Indigenous data can get lost, or erased or ignored or not documented in a way. And so part of the project that that We Count COVID focuses on is really to be able to seek out and find, using our kinship and relation systems in the city, to be able to find those folks who have had COVID and may not have been counted otherwise. Can I have the next slide, please? So how did we do this, and what model did we follow? Is that this did come about quite quickly, but what we did was we formalized our partnerships collaboration, and luckily had some experience working in the urban center around creating Indigenous governance for these kinds of research projects. And so we mobilized the community around the project. So we developed and implemented Indigenous specific public health training for our own community members. And again, this was building off of projects such as the Call Anti-COVID Indigenous Hotline, which was created at the beginning of the pandemic, and using models that were already in existence, or that already existed and that were trusted by community. The other thing was reaching out to other Indigenous folks. So one of the big things that we did around contact tracing and case identification was to reach out to partners down on the Navajo Nation who'd done a lot of work around contact tracing within their own community, to be able to talk to them about best practices and what they found was working, and then be able to, they shared the resources and we were able to adapt them to the urban setting. We set up a fixed testing site, which means that we had a building that we set up that we still run, to be able to provide COVID tests ongoing. And in order to receive a COVID test, you're offered to participate in the research, but you don't have to agree. So it's not contingent. Getting a COVID test is not contingent on participating in the research, but it is another way that we let folks know that we're doing this. We outreach to community members who have had, do have, or are at risk of COVID-19. So this is some of the things when we started to let folks know that we were trying to collect this data. We actually had community members reach out to us and say, nobody asked me, when I got COVID, nobody asked me if I was Indigenous. I wasn't captured in public health data. And so it was a way to be able to retroactively go back and count those people in, so that we would try and attempt to have a more accurate number. And then a big piece is about providing the support that folks need in order to stay healthy and navigate all of the information that's coming at them when it comes to COVID. So being able to respond in a good way and provide the support that people need to self-isolate and problem solve on an ongoing basis around how to keep them and all their household members and all their contacts safe. And then continually going back to our community governed reference group, and really keeping the focus on using our Indigenous processes to be able to provide services as much as possible. Next slide. So just the name of the site, just so that you know, is Adoje Mino Nasewanong, which means a place of healthy breathing. It's run by Indigenous folks. About half of the clinicians who work there and the outreach workers are Indigenous. We offer both saliva sampling and nasopharyngeal swabs. And as we're starting now to also provide some community testing. So folks who find it harder to come in, we're able to go and test them where they are. That's a new part. Next slide. And I'm going to hand it over to Tasha Shields to talk a little bit more specifically about our process of data collection.
Thanks, Cheryllee. Yeah, so this is very exciting. Thanks for having me here today. And I'm happy to be sharing about the database, as we refer to it, and being able to support this important piece of the overall project. It is a very complex project, having the service delivery, outreach, and data collection, the research component all together. So as Maria had mentioned earlier in when she was speaking, the importance of this database is really to be able to capture information that is not captured in census information, and as Cheryllee just mentioned, the incomplete information from public health. So this really, the purpose of this database is to do that. So it is something that was developed just for this project based on a publicly accessible data template. And in this database, we gather relevant social demographic information, Indigenous identity, testing outcome, any related travel, and access to care information. And depending if someone is coming into the testing site, or if we are recruiting them from the community, will depend on the specific questions that they are being asked. All the information that we collect is stored on a secure server and stored in separate places. We keep their personal identifying information in one place and then their database questions in another, and use a client ID, a database ID. So if I can have the next slide. So I just want to show you 2 slides here, just so you can kind of get a sense of our database. You can see here we have this study ID, we have the forms at the top, so Socio-Dem Test, Metis Test, and cases. So those are 3 different forms, 3 different pieces that are completed when someone decides to enroll in the database. In our research component of the project. If I can have the next slide. So here we're just going to go into the Socio-Dem Test. So it's just another little screenshot, and you can get a better sense of some of the other questions. So I'd already mentioned that we would collect demographic information. We do collect other information such as housing, so they're testing disposition, that just refers to if they are at the site for a test, and any comorbidities. So that information might be also collected somewhere else depending on their answers for the disposition. So those are, sort of next slide. So those are really just high level, quick look at what it might look like. But I'm going to take you through the process a little bit on how someone might be involved in the data collection in the database component, and what that how we collect that information. So on the site, on the screen, you'll see that if someone comes into the ADOSHA testing site, at that time they will be offered an opportunity to enroll in the research component. If they decide to, then we'll collect all their information and some of the first Socio-Dem test information. If they decide not to, then they can just proceed and go along with their test. We do collect additional information when they are there for a test about their clinical encounter. We'll ask information about their symptoms, collect that information that might not be captured anywhere else, and any other comorbidities at that time. We do have outreach recruitment. So that might be people who have previously had COVID who aren't coming into the site now. So we're able to go back and capture that, as Cheryllee had mentioned. So we can, the wonderful outreach workers who are associated with the site can take on referrals, or they'll put up posters, a lot of opportunities for them to engage with the community, and then see if someone wants to participate. And that really helps get a really clear picture. The difference with this, the questions that they'll be asked, they won't be asked about their current symptoms. They might be asked about previous symptoms or previous experiences, whether or not the kind of care they got at previously, everything referring to in the past. So there's slight differences, and our database will guide the interviewer accordingly. So if it's a test happening right now, it's going to jump to one screen. If it's something that's happening in the past, they'll jump to another screen. And as Cheryllee mentioned, there's now community testing, which is another great way to be able to close some of the gaps and address some of the needs in getting a COVID test. And it's also another avenue for someone to decide to be enrolled in the research piece of the project. So at that time, when they're calling to make their appointment, they can be enrolled, or they can be enrolled when the clinician and outreach worker visit their house. So right now we have almost 300 individuals registered and enrolled in the database. And so in terms of what that looks like as a rate coming into the site, it's almost 70% of people who visit the site, who visit the site in person, who are there for a COVID test, are deciding to enroll in the research. So I think that's really great, and I think it really demonstrates the strength of when something is done by the community with Indigenous organizations, the real power that has to tell a story, a really important story. So can I have the next slide? And so I'm going to turn it back over to Cheryllee. So she's going to be able to share some of the information about how this really important data that we're collecting can impact what can be done.
Thanks, Tasha. So when we think about how this can impact policy, or how it can bring to light some of the challenges that we have around vaccination injustices, really specifically what it does is if I get to the point, what it does is try and bring forward the actual count, or at least make an attempt to try and have a more accurate picture of the urban situation when it comes to COVID-19 and Indigenous populations. One of the things that we've seen with vaccination rollout is that urban centers, Indigenous folks in urban centers are, while they're on the list, a lot of the institutions that are actually receiving the vaccine don't really know, or are not terribly organized to be able to actually roll out the vaccine in a way that is either accessible or culturally appropriate. And so when we make attempts at this, at the urban level to try and show people and demonstrate, who is actually getting ill, or who is actually getting the vaccine or not, then what it does is lay bare some of the things that we know anecdotally, and speaks to some of the same issues that folks from the first presentation spoke about. And that is that Indigenous health numbers are often undercounted. People are mistrustful of systems. They don't necessarily want to self-identify if they're able not to. And there is a little bit of avoidance that goes on there in terms of engaging in the system, whether that be the healthcare system or sometimes research systems or education systems. So what it does is it also creates situations where one of the biggest things that we wanted to address was to be able to demonstrate that an Indigenous-led system within a community will actually increase the number of or make people who are generally service shy more likely to be able to come in and get tested, in creating an environment where they felt comfortable and where they knew that they were going to be treated well. And that certainly has been the case in terms of the feedback that we've been getting from the population, whether or not it's people posting on Facebook about their experience, and also the kind of card that we get them to fill out, the short evaluation card that we get them to fill out at the end. So really reducing those service barriers, what we found is that folks who would normally, might become ill or have symptoms for multiple days, they'll come and get tested earlier than they would have gotten tested otherwise, or they'll come in before they get very ill. So, they might have symptoms for a couple of days, but they're not waiting till the moment where they're like, oh, I actually think I'm very ill and I have to call the ambulance to go to the hospital. They're willing, and our outreach has been able to create a way for them to engage that's safer than the usual systems. So the other piece is, another piece is really about being able to, we had an idea that this model would work, and we wanted to try it out and really demonstrate that it would work, and then be able to provide that model or share that model with other communities, whether it be another urban center or a smaller remote community. A lot of the things that we're doing is really based on traditional kinship practices. You know, a lot of the work that we talk about that we're talking about the outreach workers doing is work that, you know, you would, you know, that like your family or other people in the community, like when somebody's ill, you can go and drop off food. When somebody's ill, you want to make sure they have everything that they need. You know, if you read all the public health information, but you're confused about how to apply it in a house where maybe you have, you know, 3 generations living, then just talking it through with somebody who can make some sense of it can be really helpful and comforting. And so a lot of those tools, whether it be practical, you know, contact tracing tools, to methods such as, you know, how do you engage and how do you provide support in a way that's culturally safe. We wanted to be able to create a model that that other communities would be able to take and adapt to their specific environment. Next slide, please. So I won't take any questions right now. I'll hand it back over to the lead to decide when that's going to happen. Thanks so much.
Thank you, Cheryllee and Tasha. Going to start my video here. And so this is the Q&A time. We are about 10 minutes behind schedule, not too bad. We have got lots of questions. We won't necessarily have time to answer them all. Some of the questions have been answered in the Q&A. Wow, I'm hearing my lovely voice. This first question we're going to direct towards Jonathan. This question comes to us from Barbara. She writes, with FNIGC's vision of the regional information governance centers across the country, what kinds of options would there be for Indigenous communities that would like to choose not to participate in the regional/national data sets, e.g. self-governance at the community level? Can you comment on the complexities regarding the need for complete national data sets, but also free, prior, and informed consent to provide data at the community level?
Yeah, that's a really essential question. And I'm going to attempt to give a short answer here because the complexities could take, well, they're complex, so it could take a while to delve into the complexities. There is a short answer that we can give, which is all options are on the table for First Nations to consider. So again, in keeping with the idea that this is not a top-down process, the central principle to our data governance strategy is community-driven and nation-based. Our current structure as a national organization is those 10 defined First Nations regions. So our governance follows that definition. And so we're working, as a starting point, we're working within that context. It is the nations within a region that will gather and will determine what they build. And our vision, if we were to use a shorthand to describe what our vision is, it's that First Nations will, at long last, be resourced to build the statistical capacity they need underneath the First Nations information governance regime they need, that we've never had. So it's the idea of building something in their image. Now, there is a need to consider coming together because communities are small, nations are small. It eliminates certain types of work one can do when you're working with those smaller populations. So that's one consideration. The other consideration is resources. And so pooling resources is a simple practicality that we have to consider. So it is not our intention to force a model or force a direction on nations within a region or a regional partner. It's to get the resources, hopefully in budget 2021 in the spring, to establish what we refer to as data champion teams who can do all that institution building that has never been done. We've never been resourced to do this. So the intention is to realize those resources to do that work. And then First Nations will have the space to ask all of those questions. What must we participate in? What can we opt out of? First Nations can already opt out of the national survey work that we do. That's already part of the process. Nothing trumps that. So that will certainly continue. And there are a lot of questions that will remain to be answered. But the process is very much getting the resources to ensure that First Nations have the expertise in place to answer, to help them ask the questions that need to be asked, and then answer all the questions that must be asked so they can truly build something in their image. Something that in a region can do unique regional, sub-regional, nation-level community work, but continue to be part of this national network doing work that is necessarily done at a national level. But the national work doesn't drive this. The national work is but a tool in a toolbox wielded by nations.
Thank you very much. We seem to have a sort of a cluster of questions that I'm going to send Cheryllee and Tasha's way. Judith, I guess, would like to know more about how Indigenous contact tracing is different from non-Indigenous contact tracing. You've already gone that to a certain extent, so I'll kind of group it in with Walter and Angela's questions. Walter wants to know, what are the cultural factors we should consider when performing contact tracing? And Angela would ask that you comment on the cultural safety and ethical issues around taking biological samples. Cheryllee and Tasha, would you like to field that one?
Sure. So I can speak about the, oh, I'm going to let Tasha start. I don't know if you can hear, but they're doing a fire alarm testing in my background.
Oh, I thought that was an
can't
alien
tell
invasion.
If you can hear it or not.
Yes, we can hear it. Okay.
Sure. So I'll start, but I'll definitely let Cheryllee comment mostly on the contract tracing, since she was involved in that much more than I have been. But I can comment on that. I think it's important to acknowledge that the kin relationships that exist within Indigenous communities, and acknowledging that is, I think, and relying on that as a part of the contact tracing is really important. And I can, I'll briefly comment on the biological samples piece, and then Cheryllee can expand on that as well. So in the database, we're not collecting a biological sample for the research component of the project. We are providing the service delivery as a COVID assessment center, as there are many COVID assessment centers around Ontario. So that is being done, and it's what we're gathering for the database is there is a specific waiver that someone can choose to sign or not sign, releasing their COVID test as a positive or negative, as a simple way to track, be able to track trends and the information. So we are not keeping that biological sample that goes to the lab with all the other COVID tests. Yeah, I'll turn it over to Cheryllee if your fire alarm stopped.
I hope it does. I arrived, I didn't know it was happening today. I'm sorry. So what else? I'll start with the contact tracing. So some of the really important things around contact tracing is really thinking through all the different touch points that people make when they're involved in contact tracing and case investigation. So oftentimes what's happening is that people often get put in the situation where they're being asked the same question 3 different times by 3 different people. And it can become really overwhelming when you're also dealing with perhaps receiving a positive result and thinking through all of the implications that has on your everyday life in the short term and the long term. Also a lot of fear that comes along with that. So a lot of the ways that thinking about contact tracing, when you think about it from an Indigenous perspective, is thinking about sometimes the language that you use when you're asking certain questions. So for example, it's something as simple as, what do you do for work? What are you actually asking when you're asking that question? You're not asking what somebody does for work. You're asking what they do outside of their home, or if they leave their home for some reason. So it's about, the contact tracing and a lot of public health initiatives. It is really about, it's a bit of a blunt object in some ways, in that you try and create, you use shorthand for things that maybe aren't applicable in other communities. So when when contact tracers say, where do you work? They're going down the line of asking, do you leave your house? Do you interact with other people? And we just can address that in ways that better reflect our own communities, with also while reducing I really apologize, while reducing, making people feel more comfortable and acknowledging different ways that we interact and move in our communities and urban centers. So that's one example that I can use. Also thinking about kin systems and thinking through integrating that piece not only around contact tracing, but integrating the piece also with support. So when you receive information, for example, that you're living in a house that has 5 people living in the house, but maybe there isn't somewhere for that person to be able to self-isolate, to be able to keep their household members safe, then you instantly have that integration of the support and the means to be able to problem solve with that person how they might like to manage that situation. And doing that in a way that understands, acknowledges Indigenous realities is really critical to building trust and actually supporting people to get the kind of care that will benefit them in the long run. And around the biological samples, yeah, I think that what Tasha said is really important to, I want to emphasize that, is that people come and they come because they would like to have a COVID test, and people opt in to be able to share their results. So the research itself actually does not receive or keep any biological sample. That is completely a clinical, follows all the regular clinical and health standards around health privacy. And what people have to opt in, it's not automatically assumed. It's actually an option. You can participate in the research and also opt not to share your results. So, but people opt in to share their positive or negative COVID results.
Thank you very much. This next question I'm going to direct to Jonathan and/or Maria, although obviously if Cheryllee and Tasha have want to weigh in. Tracy asks, is anyone tracking long COVID among First Nations, Inuit, or Métis people? I presume that means lingering symptoms after recovery, perhaps a loss of taste, loss of smell, respiratory issues. Is anyone tracking that phenomenon?
Yeah, that's a good question. Maria, in your work closer to the ground than mine, has that come up in the conversations that you've been having? I do know that in some of these sort of more national, advisory circle conversations that I and my colleagues are involved in, we do know this is an issue that First Nations are very interested in. Primary care physicians obviously are, the starting point for that information. But I don't know. That's my answer. But I do have colleagues who are a bit closer to the ground than me, so I'll turn to Maria.
Yeah, I know that they had been, the case report forms have been modifying slightly these days. And I want to say they are, but to be honest, I can't. Maybe it's with the case reporting forms that I have seen under Public Health Agency of Canada, but I don't know with regards to the data that's captured at Indigenous Services Canada.
Okay.
So within our project, I'll just let you know that folks can opt in to continue to have follow-up for up to 10 years following after, when they sign up for the research, they can opt in to being followed up for up to 10 years, specifically to be able to address that gap, because we could anticipate that there would be some folks that would get lost to the clinical system, and we wouldn't have that data.
Okay, I'll stick with you, Cheryllee and Tasha. Carolyn asks, can someone please further explain the difference between the Indigenous Health Services Fund and the Urban Indigenous Community Support Fund? Another gap in knowledge.
I don't know, Tasha, do you want to try and address this?
Or Jonathan and Maria, if you can, yeah.
Yeah, I don't have anything to add. I don't have the specifics about that.
All right. Well, if the Canadian government is watching, there's a need there in communications. Okay. Let's move on to Sandra. She asks, how will Indigenous COVID-19 collection of data be used? For example, if a single mother gets tested at Namarez testing site and is positive, Is Native Child Welfare immediately contacted to take care of her children? Who has access to data? Does Ontario Works have access to the information? How will the information be used?
So no, absolutely not. So child protection would not be called immediately to help care for the children. That would be that the information is not shared with anybody outside of the requirement to share with public health around reporting numbers. So that information is shared with public health, and that's disclosed to the client at the time where we're doing the case investigation. And then what's done is, because of the integrated model that we're using, the outreach workers can then problem solve around what makes the most sense. Can she isolate, if it's using the example of a single mother, can that person isolate at home? Do they need some support to be able to self-isolate or maybe leave their home with their children to be able to go to an isolation hotel? And what kind of extra support is needed in terms of, do her children need to be tested? Do we want to go to the house and offer saliva tests for the kids? So it's not in the integrated service is really meant in every way to keep families together and not to be able to separate folks.
Yeah, and I can comment a little bit on who has access to the information. So that is something that I oversee very closely. Everyone who has access to the database has to have gone through ethics training. They have to be added to our to the ethics by the Research Ethics Board. And we have two different kind of different areas where the information is stored, and not everyone has access to both pieces. So name, address, phone number, that kind of contact information is in one place, and then their database information, where they're positive or negative tests, any comorbidities, is stored in another place. And a very few people have access to both pieces. And so if you did have access to the information that we collect in the database, you're not going to be able to know who that is. It's just going to be a client ID number that's going to be completely meaningless. So we're able to use that information really generally to be able to inform policy later on and inform the work that is going on.
Okay, thank you very much. We're going to wrap up our Q&A. Just wanted to let you know that a couple of questions were actually answered within the Q&A box. Although we don't encourage that, I do know there's a question answered by Jonathan Dewar of FNIGC, so you can definitely check in the answered section there, but we'd ideally like to have it all spoken together as a group, as it were. Right now, I'd like to, I also wanted to mention that with regard to a question around the difference between two federal programs, of course, we do have someone here representing the federal government, Indigenous Services Canada. She will speak to that, I assume, later in the event. So just to kind of give you a heads up of what's coming. But right now, we'd love to direct your attention to a cultural performance by Coco Stevenson. He's joining us in a pre-recorded video filmed in his homeland of Treaty 1 territory. An Ojibwe and Cree singer. He's recorded 7 original albums, and thank you very much. Please enjoy.
Danse, Ani, for those of you that don't know me, my spirit name is Pimose Mayangun, which means walking wolf in the Ojibwe language. That was given to me in ceremony. My English name is Ray Stevenson, but kind of everybody all over the power world kind of knows me as Coco. Anyway, I'm going to share a couple things with you. First of all, I am a singer-songmaker, and I teach it also. One of the things I wanted to share with you is the different types of songs that we have. We have straight songs, we have word songs, and we also have fun songs. So I'll share a quick straight song with you. This is the first song I ever composed. I call it my drum song. a really short, straight song. You know, there's no words, they're just wayas and heyas. My grandfather was a Cree, so I make songs in Cree. My grandmother was a Ojibwe, so I make songs in Ojibwe. I don't speak it fluently, but I do ask people who are fluent speakers to help me out. And here's an example of a Cree song I made over 30 years ago. It translates to, I am so happy to see you when you dance for people. And it'll be just a half a verse, so short. Again, that's a Cree song that I made over 30 years ago. Most recently, I made a song that talks about our warrior women. Ogichitaakwe once, Ogichitaakwe twice, Miigwech once, Miigwech twice, Kinana Komen. We acknowledge you. So Ogichitaakwe means warrior woman. Miigwech means thank you. Kinana Komen means we're acknowledging you. So here's a sample of one of my latest songs that I haven't recorded yet. And I do have 7 CDs out, or albums, not CDs. First one I made, there was only tapes available back then, so that's how long I've been doing things. Anyway, here's a song I made for the ladies, our Ogichitaakwe, warrior women. So that's 3 different types of songs. One was a straight song, just straight chant. The other one I did was Cree. And this last one was Ojibwe. You know, the drum is used for so many different things. We use it for ceremonies, we use it for celebration, we use it as a tool to communicate with that higher power, those spirits we call grandfathers and grandmothers. And a lot of times when I make songs, I try and make songs with a purpose. So I'll share one more song with you. And this song is a fun song. It's one of the latest songs that I made, and it's in the round dance style. So it's a fun song, all right? So I guess you would sing it at a round dance, which is very popular, Saskatchewan, Alberta. Here we go. I don't know if I can go on without having you. You're the one who starts my day. You help me make it through. I just wanna say, Tim Hortons, you're the man. Hey-yo, hey-yo, hey-yo. So there you have it. You have songs that you can sing at a powwow. I have songs that I can sing at ceremonies. And that was a fun song that I made just because that's what I do. I like to have my coffee first thing in the morning. And it kind of gives it a little bit of a twist. So once again, thank you for letting me be part of this event. And anytime anybody asks me to do anything, I'm always honored, and it's always a privilege for me to be able to come and share a little bit about who I am and what I do when it comes to songs and it comes to the drums. So with that being said, there's no way for us to say goodbye, but thank you, Miigwech, and until we meet again, my friends, aho.
Ginenaskomten Ray. Let's get to our third panel. Panel 3, Indigenous Research Ethics, Enacting Data Sovereignty During COVID-19, to be presented by Robyn Rowe, Anishinaabe from Northeastern Ontario. She's an emerging global leader and advocate for Indigenous data sovereignty and governance. Robyn, welcome.
Hi.
Hello.
Great, you can hear me. Well, you just did a great job of introducing my title, so I will just jump right into the rest of it then. So I do just want to take a second actually to say miigwech to Lena for that beautiful introduction and prayer at the beginning, and Ray, that drumming was wonderful, and I too appreciate a good cup of Tim Hortons, and to NCCIH and the facilitators for inviting me to this event with so many wonderful people. So Ani Bojo Kwekwe Robyn Rowe Indishnikas, Temi Ogama Nendonjaba, Wabi Makwan Ndodam. I'm a hereditary member. My family is from Tamagami First Nation, and I am a PhD candidate in the School of Rural and Northern Health at Laurentian University. So I've been honored in my time as a student to build relationships, not just within the university, but I've really grown to be an advocate for Indigenous data sovereignty at an international level. So a lot of the things that I learn and pick up along the way, my perspectives are a little bit diverse in that they really come from global expanded conversations from Indigenous nations around the world. And so I really kind of need to give thanks to all of those people who have helped to guide me in all of this work. I also want to kind of take a second to note that I have some wonderful co-authors on a paper that is being published in the coming months. So it's been approved, it's just not released yet. So it's on First Nations survivance and sovereignty in Canada during a time of COVID-19. So Julia Rowe and my supervisor, Dr. Jennifer Walker. So I am a research associate at Laurentian University in the School of Rural and Northern Health. And I am also more recently taking on a role in the Health Data Research Network as the Indigenous Data Lead. And so with that, I just want to make sure that everybody is kind of aware of my international perspective. So I typically use language like Indigenous when I'm talking greater scale, and I'll bring that back down to First Nations. As an Anishinaabe myself, I'm more familiar with the ongoings of First Nations at a more regional level, but more broadly, I will incorporate Indigenous into these discussions. So, Indigenous nations around the world, as everybody knows at this point, have really survived repeated efforts aimed at colonization and assimilation. So Indigenous nations, no matter where you are in the world, you really share common experiences and similar narratives of things like colonialism and oppression, dispossession, land dispossession, geographic isolation, cultural genocide, and those sorts of things that have really created situations that have an impact on the way in which our nations are able to respond to a global pandemic. So in Canada, First Nations have really survived centuries of attempted subjugation, assimilation, and eradication. But really, we're not deterred by a global pandemic. Our resilience is really shining through despite the persistent narrative of disparity underscored by inequity within educational, legal, socioeconomic, infrastructure, child welfare, healthcare systems. but our people are continuing to practice our culture, share our languages, and pass on our stories and traditions. And so that is really what exemplifies this idea of survivance, that we're not just surviving, we aren't just going about our lives existing, that we are surviving along with our languages and along with our cultures. And so in the middle of a pandemic, those kinds of considerations as we make our way through this presentation is really to draw on the feelings of, this isn't just about us as people, this is about us as nations. And so ensuring our ongoing sustainability and continuing to share and pass on those things is so, so important and so relevant. So the COVID-19 pandemic doesn't discriminate, right? It doesn't discriminate between color, culture, race, creed, but the social conditions surrounding the pandemic, as so many of the presenters have kind of mentioned already, really do. So when we apply a biomedical lens within Indigenous nations around the world, what we see is that these nations are already experiencing significant disparities in health, including disproportionately high rates of mortality, higher rates of chronic conditions and associated comorbidities and complications. And all of this was happening before the pandemic even started. So in Canada, the effects of colonialism are really evidenced in things like household overcrowding in First Nations communities, lack of access to clean water, inequitable access to healthcare services, and inequitable access to primary care providers. So these factors are really exacerbated by COVID-19, and they increase the vulnerability of First Nations peoples and communities to infectious diseases and pandemics in general. So COVID-19 in many respects has re-illuminated many of the challenges and systemic inequities experienced by First Nations across the country. And so when you start to think about advancing governance, advancing conversations around Indigenous peoples' inherent rights to controlling data throughout the entire data life cycle, then you need to take a different approach. So within health systems, we really need to recognize things like, we've got conversations about determinants of health, but it's looking at it from an Indigenous lens. So taking into consideration the distal, intermediate, and proximal determinants that make up Indigenous determinants of health frameworks. So this includes the long-standing impact of social, environmental, and political inequities that are further amplified by Western biomedical definitions of health and wellness. So if you take a look at biomedical definition of health and wellness, you would say, oh, okay, there's already some disparities there. But for Indigenous people who look at a whole health approach that includes the physical, the mental, the emotional, and the spiritual, the risk of severe outcomes as a result of COVID-19 are even more exemplified because of the added burden of things like isolation and not being able to see your family. The impacts on our mental, emotional, and spiritual are less talked about, in mainstream spaces. And so it's really just taking that into consideration. So as the World Health Organization, as well as they make recommendations on the importance of controlling the spread of COVID-19 through things like hand hygiene, self-isolation, it's important to recognize that Indigenous peoples, First Nations, and communities, they're uniquely vulnerable to the virus due to, unfortunately, Canada's failure to take the necessary action to eliminate these barriers before a pandemic. So as an advocate for Indigenous data sovereignty, I really like to come in and talk about, the important impact of data. And so within Indigenous worldviews around data is anything that affects Indigenous lives at the individual or collective level, which is a little bit different than mainstream perspectives of data, which typically just look at people, one person, follow a population. But this is really, data impacts our people at collective levels. So it has the ability to also impact decision-making, influence health policy, leverage funding, improve health outcomes. But data expansions within the age of digitization are already happening quicker than we can keep up before a pandemic. So in some cases, reporting and the ways in which information are being transferred at this point during the pandemic, it's happening even quicker. And as a result, Indigenous data are being added to, and COVID is starting to lead discussions that are expediting processes within mainstream data environments that look at things like identification of Indigenous people within data sets. And when you start to expedite those processes, I've heard conversations like, oh no, it's been great. It's, you know, we've really been able to push that through, right? And so when you start pushing things through, what you're forgetting are things like the importance of collective nation discussions and governance, and those things take time. So it just becomes a deeper conversation when we begin to consider the impact of Indigenous COVID-related data gathering, usage, and access, and how these data are respectful of when we're collecting them and using them. They need to be respectful of the interests, values, and priorities of Indigenous nations and Indigenous lives more broadly. So Indigenous nations are really familiar at this point at being kind of excluded from decision-making processes, unfortunately. But we're really at a pivotal time within society, and many Indigenous nations are finding ways of navigating these and many other challenges, as we've heard today, by taking back autonomy. And globally, there's a shift happening in the way Indigenous data are managed, owned, stored, controlled, and the inherent rights of Indigenous nations are really becoming a larger part of those conversations, and including a lot more meaningful Indigenous consulted approaches, Indigenous involved led approaches. And so typically when I'm talking about Indigenous data sovereignty and governments around this point in my chat, I would really start to go a different direction. And so I would probably show you a slide about the United Nations Declaration on the Rights of Indigenous People. And I'd probably explain to you its value and how it has contributed to global discussions and advancements in the world of Indigenous data sovereignty and governance. And I would probably talk about Canada's adoption of the UNDRIP in 2015 and current legislation that is before the House of Commons. And I would likely talk about the historic passing of Bill 41 in British Columbia, who have become the first provincial government in Canada, or anywhere in the English common law world for that matter, to establish a legislative framework for the United Nations Declaration on the Rights of Indigenous People, aka the UNDRIP. I might even mention that they actually aren't walking their talk and have been called out for it in BC by the United Nations Human Rights Office of the High Commissioner. And I know myself well enough to know that I would probably delve into a conversation similar to that you heard from Jonathan and his colleague earlier around the importance of First Nations principles of Ocap and other governance structures that happen within First Nations, Inuit and Métis environments. And I would likely touch on some of the historical wrongdoings and the impact of historical experiences within research and the ways that research have really led to a need for Indigenous data governance, including things like unethical, uninformed, non-consensual collection, use, and distribution of nation-based biological samples and data. And I would likely talk about where historical examples exist. So things like gathering information without appropriate consent and saying you're going to use it for one thing and using it for another, because those things matter and those things affect the way our nations approach data and the way we consider moving forward in these spaces. I might also mention the IQ principles. These are Inuit-based principles, which I'm a lot less familiar with, but I would typically touch on them about this time. And I could probably get more specific and talk a little bit about actual Indigenous-led frameworks that are being implemented in some of the larger mainstream data spaces across the country, regionally get a little bit more specific. But as the pandemic continues to impact the country and the world, Indigenous nations are asserting their rights and sovereignty, and they're not doing this by using our frameworks that we've been creating for all these years, but through active expressions of survivance, which we see exemplified through the assertion of community sovereignty and autonomy. Now, those guides and those frameworks around Indigenous data and governance, they act as ethical frameworks to ensure that there is a clear understanding that enacting governance over nation-based information is a nation's right to do. But at this time, nations are really taking the actions to mitigate the spread of the virus and reduce negative outcomes. And they're doing this with their communities in their hearts. So most First Nations across Canada have pre-existing emergency preparedness plans and have made the necessary revisions to those plans in order to respond to this pandemic. Many First Nations communities and organizations across the country have even turned to data. They've looked to data in order to impact COVID-19 related decision-making, look at funding opportunities, and ultimately mitigate the spread of the virus to improve health outcomes for their nations. Quick actions by First Nations leadership and community members, especially at the beginning of the pandemic. I'm not sure if you've heard of some of the amazing, quick responses that were happening that really advanced nation-based sovereignty and really showcased that nations can, protect themselves. These sorts of things have more recently, you see this shift where we're incorporating things like traditional knowledges and practices into the revisions of the ways that we're mitigating in communities. And so this has no doubt mitigated the spread of the virus and has saved the lives of many. So I have some things here that I was kind of just thinking about. Just FYI, I'm almost done. So there are things to ponder, some data to ponder kind of as we go forward. And this is really for you to kind of reflect on. I'm actually not going to make any statements other than think about these things. So right now, as of last night, when I looked, there are 25.5 million reported cases of COVID being reported by our southern neighbors in the US. And the death rates are currently sitting at over 425,000. And in Canada, the total is about 262,000 since the start of the pandemic, with nearly 6,000 deaths. And this is full population. This is an Indigenous population. Now, I've read that Canada is prioritizing keeping the rates at a manageable level as to not kind of overwhelm the medical system. So the goal is not extinction, the goal is management. And so these right now, US and Canada, there's two vastly different approaches. And I probably don't need to talk too much about any further about the kind of different political positions that have led these different approaches. But what is interesting is that in Australia, when infection rates started to rise in the summer, the country implemented some pretty immediate and pretty severe laws aimed at eliminating the virus. And so right now in Australia, they have only had a total of 29,000 reported and confirmed COVID-19 cases since the pandemic began. So this is just a third vastly different approach and some data to ponder. So it's been about 10 months since we have been in some form of lockdown or another. I know that we all miss our family. I've personally never been a huge fan of hugs outside of those that my kids give me, but I would give anything to hug my parents and my siblings and my nieces and my friends and strangers who will let me near them. So in November in Canada, the known COVID cases for First Nations living in a First Nations community was 1/3 the rate of the rest of the population in Canada. So this was much lower actually than the statistic that was predicted at that time. And at that point, nations had really been implementing some evasive and culturally informed lockdown measures. And as of January 25th, there are nearly 16,000 known and confirmed positive cases for First Nations in communities. And again, these things have to do with identification. And so this is just the known number. And 144 of our brothers, sisters, aunties, uncles, cousins, elders have passed on to the spirit world as a result of COVID. And so the rate of reported cases for First Nations people living in community right now is 40% higher than the rate in the general population when addressing for the difference in population size. And I know that we're all tired of this whole thing and we're all missing our families, but I think, it's just really important to note that we don't get complacent, right? I'm bored. I want to go out there too. And that we are resilient people and we have overcome so many different pandemics and obstacles over the centuries, but we're not immune. So we must hold dear our families and our elders if we are to continue passing on our traditions, our languages, and our stories, which really are our forms of Indigenous data. So I just want to say, Chimigwech, stay safe, everybody. Bamabi.
Thank you, Robyn. We move on now to panel number 4, Indigenous Services Canada's COVID-19 update on Indigenous peoples and communities. This will be led by Pamela Wolfe-Roberge, a member of the Jibasing First Nation in Ontario. She is the Director of Communicable Disease Control at Indigenous Services Canada's First Nations and Inuit Health Branch. Welcome, Pamela.
Great, thanks, Rick. So as Rick noted, I am the Director at the Communicable Disease Control Division at ISC here in Ottawa. I grew up in Ottawa with my mom, and then I'm a member of Jibasing. And I'm joining you today virtually from my spare bedroom on the beautiful unceded and traditional territory of the Algonquin and Anishinaabe people. So today I was asked to participate on the panel to share information about how data specific to COVID-19 has been collected and reported at ISC for Indigenous populations. So what I'd like to do is I'd like to share with you an overview of what and how information is collected at ISC, an update on what we are seeing as it relates to COVID-19 infection among First Nations living on reserve, what data is missing, and examples of what we've been seeing in terms of information sharing that's supporting access to data by Indigenous partners. So right now at ISC, the system for data reporting and case notification process will see variances across the country, of course, depending on public health, PT public health systems, but in general, nurses that are working and other health professionals that are working in communities would conduct a COVID-19 test. When a test is confirmed positive, we have regional medical officers in most of our regions who are notified. In regions where we don't have regional medical officers, so for example, in our Quebec region, it may be our regional executive or the director of CDC who would be notified. When that information is shared with the regional medical officer, they would report up through their lead epidemiologist up to the surveillance group that I have in my area, the de-identified data. So they're not sharing information related to names of people, but it is just about, we're collecting information on age, sex, and where they are, so in the region. That information is then shared daily on the ISC website, so we report out at a regional level. And we also share weekly epidemiological reports, which we show some of that information I was saying about age and sex and what we're seeing across the regions. In addition to that, when the case notification system does happen, information is shared back with the community leadership, not disclosing the person, but rather letting leadership know that there has been a confirmed case so that communities are able to undertake the appropriate public health measures to ensure and to try and stop any future spread. So in terms of a summary of observations that we've seen to date with the information that we have been able to collect for First Nations living on reserve, at the height of the first wave of the COVID-19 pandemic, for First Nations communities, 57 new cases and 99 active cases were reported during the weeks of mid to late April. So that was at the height of the first wave. Since then, or I'd say not since then, but at the end of April, what we started to see is a decrease in the cases, both new and active. And we saw that continue on throughout the summer months until the end of August. So for example, we were seeing between 4 and 37 new cases and between 20 and 60 active cases between early May and end of August. And we started to see the increase in cases in the first week of September, where the numbers of new and active cases started to increase. We saw a noticeable acceleration in October, and again as recently as this month in January. We've seen cases reach new current peaks. So we've listed 2,046 new cases during the week of January 10th until the 16th. At that same time, we had 5,571 active cases. These increases in the number of new and active cases in First Nations communities are about 34 and 57 times what we were seeing in terms of the corresponding maximums during the first wave of COVID-19. And we're seeing that a lot of the current cases or the increase in current cases being driven by what we're seeing in the prairie provinces in Alberta, Saskatchewan, and Manitoba. And I think we're seeing increases both for First Nations living on reserve in communities, but also for the general population in those provinces. From what we've been able to establish, many of these cases are being linked to large and small gatherings where social distancing or masking hasn't necessarily been maintained. There are some cases where we aren't able to establish an epi-link, But I think for what we're seeing in terms of like in the Prairie Province or in some communities with the number of transmission, that it can be linked to community transmission. So overall, I'd say as we've been seeing the number of new cases expand, we're also seeing the spread of cases in terms of the spread across communities expand. So overall, the number of First Nations communities with reported COVID cases has increased from 354 to 368 just last week, week over week. So that's compared to the week before, where we had 60, sorry, I'm repeating myself, but that was compared to the week before. So last week, 368 new communities versus 354 the week before. So we are seeing that continue to increase, but it's not all gloom. We are starting to see very, very preliminary signs in terms of this week. We're starting to see the number of reported active cases decrease. So as of yesterday, we had 3,508 active cases reported versus 5,571 the week before. Time will tell if this is an ongoing trend, but of course we do hope that it's the start of a new trend of a decrease in cases. I won't share the case surveillance as of yesterday. Robyn, who just presented, provided an overview of what we're seeing with the number of deaths to date, hospitalizations, and cases. But what I will say is, while the overall case rate among First Nations is higher than what we're seeing in the general population, what's interesting to note is that the number of cases that have deceased is lower among First Nations on reserve versus the general Canadian population. It's hard to say what the driver of that is, but it could be related to the population, to the age, maybe having a larger number of the population being younger than the overall general Canadian population. Also, our hospitalization rate for First Nations on reserve is lower at 4.5% versus 7.7% in the overall Canadian general population. So I've shared with you the data that we've been able to collect amongst our network for First Nations living on reserve. The data that is missing, though, and colleagues at Fnigc and others who presented today have also summarized what data is missing. But at ISK, because we have this network of regional medical officers, in regional offices, we are able to connect with communities and regions to collect information where they share it. But what we don't have are provinces who are sharing with ISK information for First Nations living off reserve or Métis or Inuit. In some cases, we are able to gather information on Inuit living in Nunatsiavut or Nunavik, but again, that's via our regional offices and the relationships built with communities and leadership in those Inuit regions. And to date, we have seen some good examples where information sharing agreements, though, as Maria noted, it takes a lot of work to put those in place. But we have seen examples of how these information sharing agreements are supporting access by First Nations partners in accessing data and then also sharing that data out. So in BC, the First Nations Health Authority has an information sharing agreement with the province, and they're able to do those data linkages. And they do work with us and share their information with us to also report. The Assembly of Manitoba Chiefs and Manitoba Health had a historic agreement during the first wave of the pandemic where they had an information sharing agreement established, and we're now seeing information posted online by Fnigc on a weekly basis, as well as the Chiefs of Ontario, who are posting weekly information related to information that they're able to gather via the provincial database. So I'm repeating, I guess, what my panelists have said, but we know that public health surveillance information and access to that information by Indigenous populations and leaders is important. It supports and is critical for informing public health responses and also supporting the early detection and description of potential health threats present and to allow leaders and communities to take actions. As we have heard from my colleagues on the panel today, distinctions-based Indigenous-led analysis of health data is necessary to advancing culturally appropriate and science-based approaches for First Nations, Inuit, and Métis communities, and for achieving improved health outcomes in the longer term. So in the spirit of reconciliation in our work at ISK, to ensure quality and timely data, we continue to advocate and try to support where we can the facilitation of data development work that's led by or in partnership with Indigenous peoples. So for example, ISK is currently supporting Indigenous-led efforts where possible and developing options for building data governance capacity for First Nations, Inuit and Métis. So we have worked with our colleagues at the Fnigc, the Inuit Tapiri Kanatami, and the First Nations Health of the Assembly of First Nations, to support them in terms of providing, some funding to support them in working with FPT organizations and universities, working to establish those information sharing agreements or building capacity for that. We're also working to support Dr. Smiley and Cheryllee and Tasha here, the project that they presented and the community partners in their work on the center in Toronto, the demonstration project. And we did fund them with some funding that we had to support data optimization. So funding that component of the project that they described where community members are opting in after being tested. So as I mentioned earlier, I think we're committed to continuing to support partnerships where we can between Indigenous partners and other federal departments, but also provincial and territorial governments to support efforts, including data capacity building. So just a reminder before I end today that every day, if you're interested in seeing what's happening among First Nations on reserve as it relates to COVID-19, that we do post those daily at the regional level online, and every Monday we post weekly epidemiological, I was going to say studies, but that's the wrong word, summaries online every Monday, and that's available there. So I'll end it there. I think maybe I got us back on track for time, but I'll end it there. Thank you.
Thank you, Pamela. And I will take that question that I held back
Yes.
with regard to the difference between the Indigenous Health Services Fund and the Urban Indigenous Community Support Fund. If you could speak to that, please.
Yes, I'm just trying to turn on my video here. It's not working, but yes. Oh, there we go. So really, I think there's a fund called the Indigenous Community Support Fund. At the start of the pandemic, I think it was it must have been last March when it was announced. It was announced in two streams where you had like an urban component, and then you had just Indigenous Community Support Fund, and that funding was targeted for Inuit, Métis, and First Nations communities. Since then, though, we've kind of dropped the urban component of it, and not dropped but I'd say in total we're referring to it as the Indigenous Community Support Fund. So to answer your question, I would say it's the same fund. When we did work with Tasha and that project at Well Living House, we did fund them using funds that we were able to secure for data optimization specifically. So outside of the Indigenous Community Support Fund. I hope that helps to answer. But again, on our website, we have information beyond in terms of all of the funding that's been announced to date to support populations beyond even the Community Support Fund.
We have a question from Darlene, also directed at Pamela. Is there a link where ISK regional reports are posted?
So I don't believe that ISK regions are reporting on their own, but I can send, or I don't know, I can work with NCCIH afterwards to share the link where you can find the information rolled up at the regional level. So we have information that we're posting daily on the number of new cases, hospitalizations, and deaths. And also every Monday, there's on our ISK webpage, there's a link for the epi summaries, and you can see that regional breakdown on the epi summaries as well.
Okay. I'm going to direct, thank you. I'm going to direct this question from Gregory toward Pamela for her comment. He wrote in the assertion, sorry, I meant to say Robyn. Did I say Robyn? I meant to say Robyn. Gregory comments, in the assertion of sovereignty over data, isn't there a potential flip side to a protectionist stance? That is, could it lead to First Nations governments shutting down much needed research by qualified health research scholars because the delivered evidence and results paint an unflattering picture? Robyn, any thoughts about that notion being floated there by Gregory?
Hey, I have lots of thoughts on that, but I'll try to keep it brief. So when we're talking about First Nations or Inuit Métis governance and sovereignty over nation-based information, it's really important to know that in no way, shape, or form is it expected that these processes are simple. Lots of time, lots of resources, lots of collaboration, engagement, and ensuring that nations are in the position to make decisions for themselves. So we have like the work that Jonathan Dewar was talking about with the First Nations Information Governance Center, you know, their data governance strategy. It's really focusing on ensuring that First Nations have the resources to build infrastructure in order to become independent and to be credible for themselves. And so with that in mind, it's important to note that mainstream research, or you know, even as an Indigenous researcher, if I'm doing Indigenous-based research without the consent and the ongoing governance and the proper institutions put in place with partners, then I'm doing research that is not adhering to the inherent rights of nations to sovereignty and governance. And so if I, you know, which means that perhaps there are projects that should be or shouldn't be shut down based on a nation's perspective on that project. And that's how nations assert sovereignty. And so perhaps that is the impact that would have. But it's a very, we're at a point in these conversations where nations are finding ways to activate sovereignty within structures that are already created. And so dismantling those structures and rebuilding them in a way that asserts nation sovereignty, likely the hope would be that nations find ways to do that in ways that respond to their priorities in ways that matter to nations. Because whether or not an unflattering picture is being created from you know, a data set or a research project, it's really important that that unflattering picture be the choice of a nation to decide that that's the picture we are looking for right now. And so I hope that answers your question. Sorry
about that. I was having an issue there with my trying to find the audio. I'm wondering if, you know, I know that different communities seem to have different views, no surprise, about whether or not they want information about them to be out there. And COVID is no different. On the other hand, I've also heard of situations where a community wanted to know more about COVID cases, but a health authority declined to share it with them. So it's interesting how that can work either way or both ways, depending on the needs and wants of a particular First Nation.
Yeah, I agree. And of note, you know, having, if a nation is requesting nation-based data to a health authority, to Health Canada, who, you know, still holds NIHB data, for instance, which is our non-insured health benefit information for Status First Nations who access prescriptions, for instance. You know, if say the Chiefs of Ontario would like to do an evaluation of NIHB data in order to improve policy and practices within their own systems, governance shouldn't be in the hands of the federal government. So that's where, to me, like, the conversation is so much deeper. You know, we really need to make sure that governance is in the hands of the nations. And so places like FNIGC that put nations first and make sure that nation priorities are being met, that's the kind of thing that, you know, we're striving towards in these conversations around governance, so that we don't have to ask permission and be declined when you ask permission to access certain data sets from the federal government, that nations decide what that looks like.
Thank you very much. We have a question from Varen, apologies if I've mispronounced your name. Are community-specific reports being produced at ISK and shared with communities across Canada? And if I'm not mistaken, Pamela, I've heard you say that reports are happening at the regional level, which I can infer from that is a kind of aggregate figure as opposed to community by community. Is that correct?
That's correct. We're not sharing information at the community level publicly for reasons that, you know, Robyn just shared. I think in some instances communities may be open to sharing it, and others they may not. And also in some communities are just very small. So there's a privacy risk in terms of information being shared. But the regional offices do work closely with communities where there are confirmed cases, so that leadership is informed and they can take action to prevent further spread.
How does that compare with jurisdictions like the city of Winnipeg or a regional health in one of the provincial or territorial systems? How fine-grained do they get? And I mean, I'm opening up a huge can of worms here, but I think it might be useful for people to have a comparative framework.
And so it's interesting because I think we're seeing across Canada, you're seeing a variance in the level of specificity that's being shared. So for example, I remember a few months ago, Toronto shared specific neighborhoods were hotspots. And I remember it was quite contentious because there was concerns about those neighborhoods being stigmatized or the people living in them being stigmatized. Whereas in other parts, there's not getting down to that level of granularity in cities. They haven't shared it for the sole purpose of local public health units understand what's happening in their areas. They're making sure that there's measures in place to prevent future spread and to create awareness about it, but not necessarily sharing that level of detail. So I would say it's also varying across the country in what we're seeing.
Okay. I don't know if Robyn has any follow-up comments to that. Perhaps not. Okay. Well, you know what? I'm looking at the clock and it's telling me we have 1 minute to go before the top of the hour. So I think that's a good time as any to wrap things up. I want to thank everyone for sharing their questions. I want to thank all the panelists and other participants for contributing to the whole here. And of course, I want to thank all the staff at the National Collaborating Center for Indigenous Health who've made this session possible. And I do know that it will be shared in some form or fashion going forward. So if you've come in late, fear not, you will be able to access this recording at a future date. We, of course, we're very grateful to have opened today's event with a ceremony performed by Lena Ivik, and she's going to do the same to help us end off today's event. Lena.
Thank you again, and it's my privilege to be part of this event in opening and closing it, all the way from the Arctic here. It's quite not dark yet, so it's quite timely that I light this kulluk again. So I have some favorite words that sometimes surface for me when I do the lighting of the kulluk. Words like self-reliance, self-sufficiency, independence, well-being, knowing how to survive and thrive as a culture for countless of generations. All that surround this unique element of Inuit culture called the kulluk. And I believe that every time we light it through ceremony, we bring it home a little closer. This is what we thrived with when we lived on the land before settlements, and I grew up around it myself. Everything that you see when it comes to the package or the element here, all come from our immediate environment, from our animals. The oil comes from our animals. The kulluk is from the land, made from soapstone or granite. The wick that I use is tundra moss and Arctic willow that we pick from the tundra every summer. We pick enough so that we will have enough for the whole year cycle and not just thinking about winter, because we thrived knowing we have tomorrow to see. And so being the only source of light during our dark winter season, being the only source for drying our clothing because we are from the snow and ice, and our hunters, our fathers, go out every day out into the wild, out into the distance by dog team to hunt for seals, to supply our kulluk with oil, And the woman who was the center of the dwelling, the kaumak, tends to this with great care. And so when we light it, we give reverence to our ancestors. And I want to finish this closing ceremony with another ayaya or a pisik song that is from our ancestors as well. Kovia sulik punga inu neale rama ulok sulita ya 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 ay ya 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 aku tuyuk angotibuk ulok sulita iya ya 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 ay ya 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 sinilari bugun qaumatin nugusuli ulok sulita ya 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 ay ya 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 ay ya 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 ya. The song is a song of hope that we will see tomorrow again, and that I am happy that I am alive today is part of the song lyrics. And so I close this off with great wishes for everyone around our country. We're all sisters and brothers at the end of the day, and I'm very happy that we're working together. Nakolmik, thank you.